My talk is going to be slightly different from Prof. Anderson's and Prof. Davis's talk, meaning that I will show you one specimen of human atherosclerosis, and I will continue with transparencies, with slides. If we look at this human aorta, which is open longitudinally, by looking at its intimal surface, and we can see that it is irregular and it's quite full of lesions we call atherosclerotic plaques. Now, there are different kinds of plaques and there are different sizes of plaques, and these have different cellular components. If you look at small yellow plaques like this one, and at the bigger yellow one, like this one here, we can deduce that probably this bigger one has grown from the small one, and that is a natural step in the process of atherosclerosis. However, these yellow plaques of small and medium size are not the only components that we can see in this human aorta. We have some fibrous plaques and other plaques which are complicated or ulcerated. Now, what is the importance of these atherosclerotic plaques? If we look at the surface of coronary arteries or aortas covered by raised plaques, this diagram is comparing hypertensive men in dark, or in dark red, as you can see in there, with normotensive men in orange. And you can see that for different kinds of racial groups or populations across the world, going from Caucasian Americans to South African Indians, men with systemic hypertension have a higher percent of their intimal surface covered by plaques. And we all know that systemic hypertension is a risk factor for atherosclerosis. We can use the same kind of graph or representation for other risk factors such as cigarette smoking and diabetes. So what is the importance of it? It is important from an epidemiological point of view. Those are epidemiological studies that are telling you that your risk factors are going to increase the number of plaques you have in your vessels. However, if we are talking about a single individual, a single plaque can result in sudden ischemic death as long as it is strategically located within his coronary artery. Let me take you again through the different types of plaque. This is based on a study done by Starr in 1989. He looked at a huge population of young and very young people, teenagers, etc. And he described several different lesions, each one of which has a typical cellular component. The first lesion to appear is the one we call fatty streak. And fatty streak consists of foam cells, which are monocyte-derived macrophages, which have lipids in the cytoplasm. At least most of the cells are monocytic origin. The transitional lesion consists of foam cells, some of which have died and have released the cytoplasmic content into the extracellular matrix. And then we have the beginning of extracellular lipid accumulation. The advanced plaque or fibrolipid plaque is the one we see in people over the age of 30. And it's one we're going to talk about today. It consists of foam cells, extracellular lipid forming a lipid pool or a lipid core, and smooth muscle cells which secrete collagen and elastin. Now this advanced plaque can become complicated, and the process of complication involves thrombosis. This diagram represents the same elements I've mentioned before in Starry's classification. We have a fatty streak here on top with the monocytes or macrophages with a cytoplasm filled with lipid in yellow. These cells start having too much lipid in the cytoplasm and they'll die, releasing it into the extracellular matrix. This is the advanced or fibrolipid plaque, where we have smooth muscle cells forming the fibrous cap, a lipid pool, and some monocyte filled with fat. And then we have thrombus or thrombosis as complication. However, there's another kind of plaque, which is a purely fibrous plaque, which is this diagram here. And we still don't know if its mechanism is completely different from the origin, or if it is due to changes in fibrolipid plaque, or to changes in a fibrolipid plaque which has become complicated. This is what we mean by the microanatomy of the plaque. This is a transverse section of human coronary artery. This is the lumen of the artery. The artery has been stained with a special stain for fat. It will stain fat in red. And you can see the epicardial fat here, where I'm pointing with the arrow. And fat forming the lipid pool or lid core here. The fibrous cap, consisting of collagen and elastin, surrounds the lipid core, and there's a layer of endothelium lining the lumen. Another way of looking at it is looking at plaques from the aorta. If you remember the plaques I showed you before, and you imagine that we cut through them, this is what we are going to see. We will see the aortic wall consisting of elastic fibers and smooth muscle cells, And this is the atherosclerotic plaque. We can see the lipid pool and the fibrous cap surrounding it. I want to go back to the cellular component of the plaque, because they are very important to understand why a plaque becomes unstable or why a plaque ruptures. And you will see during the talk little by little that the players in the game increase in number and the complexity of their interactions increases as well. Now this is the same aortic plaque we saw before, but this time we have used a monoclonal antibody which is marking macrophages. And you can see that there are two groups of positive cells in red, dark red here, just at the shoulder of the plaque, at the edge of the lipid pool when it touches fibrous cap. This is a close-up view of same plaque. We can see lipid pool around here with cholesterol clefts, and around the shoulder in the fibrous area we have positive cells staining with this monoclonal antibody for macrophages. So what are the names of the players in this game? We have the endothelial cells, the monocytes, plasma LDL, T lymphocytes, platelets, and smooth muscle cells. We know that the monocytes cannot ingest plasma LDL as it is. Plasma LDL needs to undergo a series of chemical processes and become oxidized so that it can be recognized by the scavenger receptor in the monocytes. The other thing we know is that the scavenger receptor is non-down-regulated, meaning that the monocyte can eat as much oxidized LDL as it wants. It will never feel full. And that is the reason why, at some point in time, the cytoplasm will rupture and the monocyte will release the cytoplasmic contents into the extracellular matrix. I'm not going to go into the chemical modifications of LDL into detail, but just remember that we have native LDL in plasma, and the first chemical step is increasing the number of double bonds and producing lipoperoxidation, increasing the number of lipoperoxides. And that is done either by means of free radicals. If you culture LDL, it is done with copper. And the other thing is that where is it done? Well, it has been shown that the epithelial cells have the capacity to trigger this process. So do macrophages. And apparently, so do smooth muscle cells as well. So once we have started this chemical transformation of LDL, and we have increased the number of lipoperoxides, we call it seeded LDL. And this seeded LDL will be split into ketones, aldehydes, and other elements, of which one will be modifying the aldehydes. It will be modifying one residue of the ApoB, and that will induce the expression of a new receptor so that it can recognize oxidized LDL. The other important thing is that when LDL starts being oxidized, it changes the way it acts on different substances which are also involved in the process of atherosclerosis. Minimally modified LDL, just before it becomes oxidized, acts both on endothelial cells and smooth muscle cells, producing an increase in the expression of cell adhesion molecules. And I'll go back to this in a second with another graph. An increase in the expression of interleukin-1, monocyte chemotactic protein 1, which is going to attract more macrophages into the area, monocyte macrophage colony stimulating factor, and platelet-derived growth factor. So what's the role of all these fancy names? And we know that the monocyte needs cell adhesion molecules expressed on the endothelium in order to be able to stick to the endothelium and to move on the endothelium. We also know that, for instance, platelet-derived growth factor is going to stimulate the smooth muscle cells so that they produce more collagen. As you can see in the graph, the interaction between the different cell constituents and smooth muscle cells and the final production of collagen, which is one way of growth within the plaque, is very, very complex. And this graph is probably 14, 16 months old. I don't want to imagine what the next one is going to look like. The last element I want to mention, and that is fibrin and thrombin. That looks nice. Both of them stimulate smooth muscle cells so that they produce collagen. And the presence of fibrin has been shown using monoclonal antibodies in very low quantities in normal arteries, but in very high quantities in diseased atherosclerotic arteries. So once again, this is what we call microanatomy of the plaque. And from all graphs I've shown you before, we can deduct that one of the mechanisms for plaque growth is just increasing in the amount of lipid that is deposited within the plaque and increasing collagen. And what we see here is a transverse cut of a coronary artery with a severe stenosis. This is the lumen, which is very, very small. And you can see the lipid pool, bright yellow, and the fibrous cap surrounding the lipid pool. mechanism for plaque growth is thrombus. And although in 1994 everybody is aware that thrombus is the underlying factor in acute myocardial infarction, unstable angina, and sudden coronary death, it wasn't that clear until the mid-70s, when cardiologists, invasive cardiologists, started performing coronary angiograms in patients who were having an acute myocardial infarction. And that was when they described what is called the type 2 angiographic type stenosis with irregular borders and the filling defect. Postmortem angiograms and postmortem histologic examination of the coronary arteries confirmed the presence of thrombus. And most important from a clinical point of view, the huge success of thrombolytic therapy in patients with acute myocardial infarction sort of sealed the definition of thrombus as the underlying factor in these acute ischemic events. So let's see what happens in a coronary artery of a patient who is having an acute ischemic event. This graph shows a coronary artery with an atherosclerotic plaque. The lipid pool here is in yellow. The fibrous cap is black and thrombus is red. There are two mechanisms for acute ischemic events. I will talk first about the less common one, which includes about 25% of patients. That is superficial intimal injury, in which we have focal endothelial denudation or loss of endothelia over one area of the plaque, and it's over this area that we're going to have a thrombus. Although the thrombus is shown as being small on this graph, it can grow to be big enough and occlude the artery. The other point to make is that in superficial intimal injury, the lipid pool is intact and the fibrous cap is intact as well. This is thrombus at usual microscopic level. There is an area here without collagen, without endothelial cells. You can see the platelets adhering to subendothelial collagen. This is an example of superficial intimal injury with a very small thrombus which does not modify the degree of stenosis of this artery. The lumen of the artery is here. This is the plaque with its lipid pool, and you can see that the lipid pool is intact and the fibrous cap is intact as well. This is another example of superficial injury. This is the fibrous cap which is intact, lipid pool, and we can see that the thrombus is occluding the lumen of the artery. Let's go go back to the same graph for a second and try to explain what happens in deep intimal injury. You can see that the black area here is torn or broken. There's a fissure, a tear in the fibrous cap, and that allows blood from the lumen to enter plaque, and you start having a thrombus within the plaque as a first step. This thrombus might grow, and it might include the lumen, or it might just protrude slightly into the arterial lumen. This is another example of deep intimal injury. The lumen of the artery is here. This is the thrombus, and you can see that it is not protruding into the lumen. It is not modifying the degree of pre-existing stenosis. But you can see clearly that there has been tear there. This is another example of deep intimal injury. This is the lumen of the artery. This is the fibrous cap, and there's a break here, and the thrombus is occupying the place of the lipid pool, but it is not protruding into the lumen. This is another example of deep intimal injury. Once again, the lumen of the artery is here. This is the fibrous cap, which is torn at this level. The thrombus is small. It's within the lipid pool. It is not protruding, but one of the areas of the fibrous cap which has been torn protrudes into the lumen like a flap. And this is a deep intimal injury where the thrombus has grown to be big enough to occlude the lumen. This is lipid pool, and you can see the thrombus coming into the lumen from the lipid pool. This is fibrous cap and the area where it has been torn, and the thrombus is occupying the lumen, the entire lumen. So you see that we have a high variability in the amount of thrombus protruding into the lumen. And we have all these options whenever a plaque fissures. The fissure can heal in such a way that the degree of stenosis after the fissuring will be exactly the same as before. However, if the thrombus protrudes into the lumen, when it heals, it can leave a residual high-grade stenosis, or the protrusion can be such that it can occlude the lumen. In this case, when it heals, we end up either with a chronic occlusion or with a multi-channel recanalized, as we call it, residual lumen. And do these coronary thrombi heal? Yes, they do heal. You can see one on your left-hand side, and another one with a much more severe stenosis than before on your right-hand side. So now that we know that we get a thrombus and we get a tear in the cap of the atherosclerotic plaque, Let's try to see why that happened. From the mechanical point of view, fissures or tears in the cap reflect the interplay between the mechanical force that is exerted on the cap and the physical strength of the cap tissue itself. Now this sounds very sophisticated, and what I'm going to show you is even more sophisticated. We looked at coronary artery plaques, and using mathematical models and the simulator, we calculated the degree of stress on different areas of the plaque. And what this graph is showing is that the point of highest stress is at the edge of the plaque. I'm talking about the plaque with a lipid pool. If we take the same atherosclerotic plaques as we used in this experiment, and we look at their cellular constituents, we will see that there is an increased number of macrophages around the area where the stress is increased. So after doing that, we were trying to define if there was any difference between the type of cellular components in stable plaques when compared to unstable plaques. And we looked at stable and unstable plaques of aorta, men aged under 69, and we measured the percent of lipid pool, or which percent the total volume of the plaque consisted of lipid, and the number of smooth muscle cells and monocytes. If we look at the stable plaques, we will see that the lipid pool, which is the axis going in this direction, is relatively small. If we compare this with the unstable plaques, we will see that the size of the lipid pool is relatively big. And as a matter of fact, it is over 40% in this group. The second variable we looked at was the number of monocytes or macrophages. We can see that the number of macrophages is low to intermediate in stable plaques, and it is much higher in unstable plaques. On the other hand, when we look at the number of smooth muscle cells on the x-axis, we can see that stable plaques have many smooth muscle cells, whereas unstable plaques have a few only. So what do we get out of this? We get a profile for a high-risk plaque, or a plaque at a high risk of fissuring or rupturing. And that is a plaque where the lipid pool is over 40%, where there are a lot of macrophages and not that many smooth muscle cells. And what kind of plaque is that? The one we're looking at on the screen, with a big lipid pool and a fibrous cap which is becoming very thin, even dangerously thin, around here. So to summarize, we know now the way fibrolipid plaques show progression of disease is by two mechanisms. We've looked at primary growth with increase in the size of the lipid pool and smooth muscle cell proliferation. And this is probably a slow process, as far as we can guess, resulting in chronic obstruction of the coronary arteries. The other mechanism is thrombus. We can have a major thrombotic event, and that will translate into clinical symptoms, meaning acute infarction, unstable angina, or sudden death. But we can also have minor or small episodes of thrombus, which will result in an increase in the size of the plaque, probably by a mechanism equal to the one seen in primary growth, with proliferation of smooth muscle cells. The point to remember is that many of these minor episodes go unnoticed clinically, and it's very difficult to determine if, in retrospect, when we as pathologists look at coronary artery plaques, what minor clinical symptoms were present, if at all. Thank you.